initially these things are done like Donald Trump, for example, was initially started off as a joke figure, a bit of controversy. Let's get him on. It'll get flow through our websites or our news channel, and then before you know it, this is what I've written. We've seen the era of fake news. Fake science is going to happen. And it destroys patient-doctor trust, because now a patient, having seen this on the news, on NPR, will think, oh, well, why isn't my doctor giving me vitamin C? Whereas I'm actually practicing best medicine. And best medicine dictates you don't even consider it as it's a proof of concept. So, that was I was disappointed, because it's not the first conference I've been to where I've seen this charade.
I guess. But wow, that was way beyond anything I've seen before. I've seen people feel passionate about their discovery or something like that. But not to that extent. It's weird.
I think it's just so it's so sad. This is what it's come down to. Anyway, I was very, very disturbed by it, I have to say.
Oh, me too. And then Cuthbertson's vitriol, I understand his point. Frankly, I agree with it. But I have a feeling you could have said it maybe a little nicer somehow.
But it should never have got to the point where Brian Cuthbertson has to get up and say that to someone. That's not what we should be about. And I was very sad to see it.
Go for it.
Hey, good afternoon, everyone. Welcome to Grand Rounds. This is Critical Care's turn to do Grand Rounds. And we're very fortunate to have Pratik Sinha. Hopefully I got that.
Yeah, you got that right.
Oh, okay, fantastic. As our speaker today. He's followed an interesting pathway. He trained initially in the UK. His primary specialty is emergency room training. Then got involved in critical care and did his critical care training, and as subspecialty training also ECMO. Then partway through his career decided with his family that they wanted to go to the States and do some research training. And so it's really his research training that he's going to talk to us about, but obviously a guy who knows a lot about the clinical problem of ARDS. Very much looking forward to this talk, which is ARDS, a syndrome in distress.
Thank you. And can everybody hear me? Yep. Excellent. So, the title of my talk is ARDS, a syndrome in distress. These are my credentials, and I have no disclosures. I do have a disclosure. I've got 3 children who are 5 and under, and apart from being a physician and a scientist, my greatest contribution to medical science has been donating my upper respiratory tract as a reservoir for all manners of viruses. And unfortunately, I'm in the grips of one of them, so I apologize for any coughing and spluttering. So the outline of this talk is going to be along the lines of, I'm going to first give a brief overview of where we are with ARDS, and I'm going to give you some evidence base on how we manage ARDS, and that section is going to be very short. But I'm going to also, alongside in that section, give some of the evidence that may suggest that there are some interventions we might want to use or consider. Then I'm going to focus, and the next half of the talk is going to focus on the research limitations and what the current limitations are of what we understand ARDS to be. And then finally, I'm going to present research from our group, which offers some potential solutions, albeit at a very early stage. So this landmark paper, which came out in The Lancet in 1967 by Ashbauer and colleagues, and this was really the first time it was ARDS was described in an organized fashion. They presented a case series of 12 patients that presented with a multitude of etiologies, mostly trauma, but also viral pneumonitis and aspiration pneumonia. And this is how they summarized the syndrome. The respiratory distress syndrome in 12 patients was manifested by acute onset of tachypnea, hypoxemia, and loss of compliance after a variety of stimuli. They proposed that using PEEP might be helpful in these patients, but fundamentally, the other thing that they emphasized on, that treating this relied on treating the underlying problem that led to this syndrome. And also they suggested that hydrocortisone might be useful, although they weren't certain about the efficacy of that drug, and it's good to know nothing has changed 50 years from then. Right, so in this helpful timeline by Art Slutsky and colleagues, they have mapped out what progress we have made, both at the upper half of this timeline. You can see the progress we've made in bench science, and this has been appreciating of barotrauma, volutrauma, biotrauma, and really what this is about is understanding the underlying mechanistic pathways that lead to acute respiratory distress syndrome. And on the bedside, again, going all the way from mechanical ventilation to some of more recent trials which have shown a benefit with particular interventions. And these are the bits that I'm going to focus on mostly. So where are we with ARDS now? It is diagnosed or defined by the Berlin definition, and that mandates that you have ARDS if you fill the following criteria. You have a PF ratio of less than 300 millimeters of mercury, and this is further subdivided into mild, moderate, and severe. If your onset is acute, i.e. within 7 days of presentation of your symptoms, and if you have bilateral chest opacities on radiograph, and there's also the caveat that's not fully explained by cardiac failure or fluid overload, and you're undergoing invasive mechanical ventilation with a minimum PEEP of 5. And this is an iteration of a previous definition, which is called the AECC definition, which was in 1994, and this just builds on that and with a few minor tweaks. In terms of risk factors, broadly speaking, they're divided into direct and indirect causes of ARDS. Of the direct causes, pneumonia is one of the most crucial risk factors and constitutes, in most randomized controlled trials or in observational data, normally constitutes about 50% of the cases. Other important direct causes are aspiration of gastric contact or aspiration pneumonia, and pulmonary contusion. In terms of the indirect causes, probably the most important one that's described is non-pulmonary sepsis. Other notable causes are pancreatitis and, of course, trauma that's non-pulmonary. So what do we know about the pathophysiological features of ARDS? And quite a lot of progress has been made on this front. Fundamentally, the hallmark, the pathophysiological hallmark of ARDS is an acute inflammatory process. And as a consequence of that, we see some endothelial dysfunction. We also get some epithelial injury, and you also get some intravascular coagulopathy and coagulation. And all of this macroscopically leads to sort of pulmonary edema, increased alveolar infiltrates, and there's also intrapulmonary shunt, and you get increased intravascular lung water. And microscopically, this manifests traditionally what was described as the histopathological hallmark of ARDS was diffuse alveolar damage. And on the left in slide A, what you see is a normal-looking alveoli. And on the right, on slide B, you can see that there's lots of nucleated cells in the alveoli, which are probably leukocytes. And the yellow arrows are pointing towards hyaline deposits. And this is what traditionally we've understood to be the histopathological hallmark of ARDS. Moving on to managing ARDS, and I will emphasize once again that I'm only going to present sort of high-quality evidence that suggests that interventions we may be able to use, and these are mostly trials that have been run over the last 20 years. There are 4 arms of strategies when we look towards managing patients in ARDS, and that's mechanical ventilation, and then some adjuvant supportive therapies on top of that. I will touch upon ECMO and disease-altering medications. So let's start with mechanical ventilation. So this seminal paper, which was first published in 2000 by the NHLBI ARDS network, and these investigators tested low tidal volume versus traditional ventilation, which we now call high tidal volume. And they had 2 groups, the control arm, which is in red. The mean tidal volume in this group was nearly 12 mils per kilogram. And again, the study was done before I was a physician, but I'm reliably told that it was frequently practiced where people used tidal volumes of upwards of 10, 12, 14. And really, there was a focus on trying to keep your arterial PCO2 within normal range. And in terms of the treatment arm here, the mean tidal volume was 6 mils per kilogram, and there were approximately 430 patients in each arm. And as you can see, there was a significant mortality benefit, where in the treatment arm, mortality was down to 31% compared to nearly 40% in the control arm. And other metrics of clinical outcome, such as ventilator-free days and number of ICU organ failure-free days, were also significantly in favor of the treatment arm, or the low tidal volume arm. Since then, there have been numerous trials which have also looked at alternative ventilatory strategies in randomized controlled trials. These include high PEEP, and these are just some notable inclusions. There have been really numerous trials, which I don't really have time to present them all, but notable ones are high PEEP versus low PEEP, open lung ventilation, esophageal pressure-guided ventilation, and high-frequency ventilation. And all of these trials have been negative. So currently, low tidal volume is the standard of practice in ARDS. Moving on to adjuvant supportive therapies, the next trial I'm going to present is called the FACT trial, and I'm only going to focus on the 2 fluid management strategies in this trial. The treatment arm was a conservative fluid management strategy, and at day 7, these patients were in neutral fluid balance, compared to the sort of the liberal fluid arm, where there were 7 liters positive at day 7. So what were the outcomes? Again, there was no significant difference between mortality in the 2 groups. There's 25 compared to 28. But what was significantly different was that the conservative fluid treatment arm had a significantly higher ventilator-free days than the control arm, or the liberal fluid arm. There was also differences in ICU-free days that was favoring conservative fluid management. So taking this data, there's probably some evidence to suggest that it might be useful to implement a conservative fluid management strategies in some patients, although this evidence isn't entirely clear, because these were secondary outcomes. The primary outcome in this study was mortality. Okay, moving to some more recent studies now. So there was this trial is called ACURSYS, and this is a French randomized controlled trial, multi-center study, which looked at neuromuscular blockade versus placebo in severe ARDS. It's also worth noting that they only recruited patients with a PF ratio of less than 150. So I'll just remind you, the normal definition means you have to have a PF ratio of less than 300. But in this case, the patients were only recruited if they had a PF ratio of less than 150. And in this study, they found that there was a significant survival benefit. I think this chart's come out too small, but the top line is cis-atracurium, and the bottom line is placebo, and there was a significant survival benefit with cis-atracurium therapy. Mortality at 28 days was also significantly lower in the cis-atracurium group at nearly 24% compared to 33%. However, when they looked at in-hospital mortality, so when they extended the period of study, they found that although there was a trend towards benefit with cis-atracurium therapy, this didn't reach statistical significance. One of the other things that's worth noting is that the study was actually relatively quite small. There were only 170 patients in the treatment control arm, and we're soon expecting a bigger trial, the ROSE trial, which I know has stopped recruiting, and the results are pending, but that will help inform us whether or not we should use neuromuscular blockade. So the jury is still out here. There does, however, there is much stronger evidence for prone positioning. This is the PROSEVA trial, again run by the French group, and it was a randomized controlled trial where patients were randomized to either prone positioning or supine therapy. Again, they only recruited patients that had a PF ratio of less than 150. So if we look at death at 90 days, there was a significant benefit. So mortality was significantly lower in the group that underwent prone positioning, 24% compared to 41%. And the magnitude of this finding is quite significant and probably unique in critical care practice. And other metrics too, such as ventilator-free days, were quite significantly in favor of prone positioning. And again, prone positioning confirmed a significant survival benefit in these patients up to day 90. So we're going to go next to ECMO. And I probably should have given a second disclosure that I worked during my training during my critical care training. I worked in ECMO units for a year, so I have some underlying bias, and this will become clearer as I move along with these studies. So the first trial I'm going to present is the CESAR trial, which was published in 2009, and this is a trial from the UK. Again, this was a multi-center trial which randomized patients into ECMO or conventional mechanical ventilation. And again, these patients were very unwell. The Apache scores were very high and the PF ratios were very low. It's also important to remember that only 68 of the 90 patients in the treatment arm actually underwent ECMO. So in reality, what this is actually they present this as an intention to treat analysis, but really what this trial is studying is, do patients do better if they get referred to an ECMO center versus if they get managed at the parent hospital? So this is asking a slightly different question. And they found that there was I could answer it. All right. This is... They showed that people who were referred to the ECMO center did have a significant risk reduction in mortality. Although, again, the caveat of this study is that it's an incredibly small study. There were only 90 patients in each arm. So more recently, relatively hot off the press, is the EOLIA trial, which has generated a lot of controversy in the specialty and really has kind of divided us as to those people who actually, in inverted commas, believe in ECMO and those who don't. And I don't think this has really clarified any of the issues. Let me point out a few things about this trial. It's important to appreciate that this trial was stopped for futility. They only recruited 240 of the intended 330 patients. And it's also important to appreciate that these 240 patients were recruited over a period of 6 years. Really, that's not a lot considering how many centers were involved in the study. There was no significant... I don't think can you actually see that? The p-value here is 0.07, but there is no significant difference between the ECMO group or the control group. However, there is a trend towards a survival benefit. And other key factors, such as, this is so small that even I can't read it, but what it says is that the primary endpoint for mortality at 60 days, again, there was a trend towards improvement in the ECMO group compared to the control group. However, this didn't reach statistical significance. Now, this section is very interesting. It's unfortunate that probably most of you can't read it, but I will read it out. What this says is that key secondary endpoint was treatment failure at 60 days. And the treatment failure was statistically significant in the control group, so much so that 35 patients out of 125 ended up switching over to the control arm. And this is important because it suggests that many of these patients would have probably died had they not been put onto ECMO. And I say this from a position of bias. I've studied the 35 patients that were switched over onto the treatment arm. 9 of them was during cardiac arrest. And I think it would be fair to say that those people undergoing really quite high pressure, high volume mechanical ventilation who undergo cardiac arrest after a period of treatment normally end up dying. The statistics are stacked against them. However, they were switched over to ECMO. And so people who do use ECMO have kind of lost equipoise in the setting of this patient. However, it doesn't mean, and I'm not saying, that we should use ECMO on all patients. As a rescue therapy, I still remain unconvinced that this wasn't a positive study, albeit that the study doesn't show it, and that wasn't their primary intention. It also highlights that there are some technical issues with trying to conduct studies when you're testing ECMO against conventional ventilation. And these are highlighted by the fact that recruitment in the study was so slow. The first study that I showed you by Giles Peak, which was the CESAR trial, that was done before the era of prone positioning. And we're not really sure how prone positioning interacts our sort of pathway, decision-making pathway to trying to instill ECMO in these patients. Certainly in the UK, where we have a very specific pathway towards ECMO. Our mortality rates in ECMO are 80%, but that probably suggests that we're not proning enough people and probably using ECMO too early. So we don't really know. However, I still think that ECMO has a role in terms of rescue therapy. So how do we consolidate all of this information? Well, very helpfully, the American Thoracic Society got a bunch of people together, and they put out a guideline towards how we use mechanical ventilation in the setting of ARDS. And what I've done is I've split the table into recommendations and my own personal practice, because I have the privilege, I'm stood up here, so I get to do that. So low tidal volume ventilation, currently there is a strong recommendation to use it in ARDS. In my own practice, I pretty much use it for all patients. Even when I'm doing anesthesia in theatre, I tend to use people with low tidal volume ventilation. How about prone positioning? There's strong evidence to recommend that we use it in severe ARDS, and I agree, I think the evidence is pretty compelling at the moment. High-frequency ventilation, which was during my training, which was in trend, and actually we used to use it quite a lot. There is no evidence to support its use, and I agree with that. Higher PEEP versus lower PEEP, there's this thing called conditional recommendation in moderate and severe ARDS, which is not entirely clear. Personal approach towards PEEP is that I try and individualize it to patients, and it's very much dependent on their body habitus and what the areas of consolidation is like and what the pattern of disease is before you make that decision. However, rarely in patients with moderate to severe ARDS that I use PEEPs of less than 10, and I tend to use a sort of a decreasing incremental PEEP strategy to find optimal PEEP. Recruitment maneuvers, this is a conditional recommendation. And my own personal feeling of this is that in severe ARDS patients, if we're considering using recruitment maneuvers, it may be healthy to start thinking about whether or not we need to start proning these patients. And finally, ECMO, their suggestion is additional evidence is required. From my personal perspective, taking the data that we have at hand, I think there's probably use for this in some very specific severe ARDS patients that aren't responding to conventional mechanical ventilation. Okay, so we're now transitioning to the next phase of this talk, which really looks at disease-altering medication. So what evidence do we have of disease-altering medication? These are a list of randomized controlled trials that have been conducted. By no means is this list comprehensive, but what it shows, and I will help you, is that all of these trials have been negative. So the question is, why are so many clinical trials in ARDS negative? One of the things to engage with is the sort of the growing dichotomy between what we understand the clinical entity of ARDS and what we understand ARDS as a biological entity. On one hand, we have somebody with a PF ratio of less than 300, bilateral chest X-rays, and acute onset of disease. And this is actually very frequently encountered in patients who are on mechanical ventilation. And on the other hand, we have this amazing insight into these disease processes. What we can probably say for sure is that we're not studying the same things. And previously, when diffuse alveolar damage was considered the hallmark of the histopathological findings of these patients, it's very interesting since the introduction of the AECC definition, we have now found in multiple studies that diffuse alveolar damage is only seen in about 50% of the patients with ARDS. So the question is, has ARDS changed, or are we just capturing a very broad group of patients that we're trying to coalesce into the same clinical syndrome? And all these pictures that you see here can all ultimately cause ARDS. So it's hardly surprising that we have an immense amount of heterogeneity in these clinical syndromes, because we try and coerce these pathologies and we try and coerce these etiologies all into the same syndrome. And there are numerous lines and factors that lead to heterogeneity in ARDS, and this can be clinical, physiological, biological, temporal, i.e. how far patients are in terms of the disease process when they present, and there is genetic differences, not just in host response, but if you're looking at infective organisms, the organisms themselves will have variation in their genetics. But there are silver linings, and where most weak-willed medical specialties would have given up in trying to do more trials in the face of these unrelenting negative trials, us intensivists have continued to do lots of trials. And that's great for people like me because I love data and there is lots of it. So the question is, can we use these levels of these factors or levels of heterogeneity either on their own or in composite to try and harness this data and find homogeneous subgroups within ARDS that can help us and inform us with conducting better clinical trials and have a meaningful impact in terms of our clinical practice. So the explicit aim of the work that we do, which is to try and find subgroups in ARDS, is so that we can conduct better trials. It's to capture a study population that will enable more efficient trials and more likely to result in positive findings. And this phenomenon is known as trial population or study enrichment. And there are two underlying strategies towards this. The first is prognostic enrichment. The idea here being that you identify a subset of patients that are more likely to encounter an outcome of interest. So, for example, in ARDS, that might be mortality, or whether mortality is the best outcome in ARDS is up for debate and probably not for this forum. We have successfully already used prognostic enrichment in ARDS. And these two trials, which I showed you before, the ACURSYS trial and the PROSEVA trial, which looked at prone positioning, they only selected patients with a PF ratio of less than 150. And these people are more likely to die than if we included all comers in ARDS. The next thing is predictive enrichment. And in my line of research, this is essentially the holy grail. And the intention here is that you identify a subset of patients that are more likely to respond to a specific intervention. Whilst there are no working examples of this in critical care, in oncology there are multiple examples where targeted therapy are used for tumor cells that express specific either proteins or their genotype, and these have been shown to confer a survival benefit in selected populations. So first, the first bit of data I'm going to show you, and largely speaking, I have two arms of research that I'm engaged in, which is one is applied clinical physiology, and the other is molecular phenotyping. I'm going to present the physiology stuff and how we can prognostically enrich this population. So the PF ratio is the only measured physiological variable that is used to define ARDS. Yet we know that respiratory failure in gas exchange, there are two distinct pathways. There is oxygenation and there is ventilation. Failure of ventilation is a largely ignored parameter in critical care and in mechanical ventilation. This despite the fact there being some pretty good evidence that it's an important predictor of outcome in ARDS. This study is by Nuckton and colleagues, which was published in the New England Journal in 2002. And they looked at physiological dead space, so that's the dead space fraction. So that's the portion of your tidal volume that does not engage with gas exchange. So they used that fraction to see whether they could predict outcomes in ARDS. And they found that it was, in multivariate analysis, physiological dead space was a significant predictor of outcome. Subsequently, there have been numerous studies, and again, this list is by no means exhaustive, that have shown that either dead space, a surrogate of dead space, or other measures of ventilatory failure have all shown that they're a useful predictor of outcome in ARDS. But we don't use them because measuring dead space can be quite cumbersome. There is no easy way to do it. Well, there is an easy way to do it using volumetric capnography. However, most ventilators or measurement systems don't have this in line, and it's often an add-on, which is expensive. And so it hasn't really taken on, even though this evidence has been around for coming up to 2 decades. So part of my PhD was to develop a simple index that could track impaired ventilation or impaired CO2 clearance at the bedside. And what we developed was ventilatory ratio, or VR. And VR is your minute ventilation multiplied. So this is the bit you may have to concentrate for a little bit. So that's your minute ventilation multiplied by your arterial PCO2 divided by a set standard for these values. And the set standard for minute ventilation was predicted 100 mils per kilogram of predicted body weight. And your ideal PCO2 was 37.5 millimeters of mercury. And the reason why we used 37.5 was because I was trained in the UK and we used kilopascals, and 5 was a convenient number. Had I been in the US, I probably would have chosen 40, but I'm going to wait for the world to catch up and start using proper metrics of measuring pressure. To put it simply, VR is easy to calculate. All you have to do is you multiply your minute ventilation in mils per minute by your arterial PCO2, and then you divide it by your predicted body weight and 3,750. VR is a unitless number, and a value of 1 roughly represents a normal ventilating lung. And if any of you are interested in the paper that I've cited at the bottom, this is based on very sound physiological principles, and there's about 20 or 30 equations that you can go through that shows that VR is closely related to 2 factors, dead space and the volume of CO2 production. Using ventilatory ratio in 3 ARDS network trial dataset, we have shown that it's an independent predictor of mortality after adjusting for Apache score, PF ratio, and PEEP. And that it can be used, if we use the median value of VR, we can split the population into clinically meaningful subsets. The patients with high VR had a mortality rate of 39.4%, and those with a low VR had a mortality rate of 29%. So the objective of this new study that I'm about to present was to test whether VR was associated with dead space in ARDS. Additionally, we'd only shown its use, which was limited to randomized controlled trial setting. We wanted to see whether we could use VR in an observational cohort, and then we wanted to see whether we could use VR in so some of the studies that I'd shown you in the previous slide were all in an era before lung protective ventilation, so we wanted to see whether it stood up to the rigors of modern practice of mechanical ventilation in ARDS. So the study population we used was in the San Francisco General Hospital, which is a local hospital in San Francisco. All patients underwent mandatory modes of ventilation. This was by and large volume control ventilation. Patients had dead space measured at baseline, which we agreed was at any time within 12 hours of their admission to the ICU once they'd been diagnosed with ARDS. And we used volumetric capnography to measure dead space. Respiratory variables that were measured at the time of dead space measurement were used to calculate VR. We screened about 1,020 patients. Of these, 520 patients had the requisite measurements in order to enroll into the study. This is to give you an idea of the study population. Important things to note are that there were disproportionately higher numbers of men in this study. That's because San Francisco General is a trauma center, and I think it's now a well-established fact that men have delayed brain engagement and a tendency to get themselves into trouble. Also important to note is that the Apache scores were obviously higher in non-survivors compared to survivors, and in the survivors, pneumonia was a greater fraction of the patients that presented with risk factors of ARDS, whereas sepsis in the non-survivors was the highest proportion of risk factor. So on the chart that you see on your left shows the relationship of VR. The correlation coefficient here was 0.66, and this was probably in the range of what we'd expected. Our previous studies, albeit in smaller populations, showed that the correlation coefficient between the two variables was 0.7. In the chart that you see on your right, in quartiles of VR, you can see as we go incrementally higher quartiles that the dead space fraction was higher in these patients. Looking at its clinical utility, we found that VR was an independent predictor of outcome. After adjusting for PF ratio, the odds ratio was 1.6. After adjusting for PF ratio and PEEP, it was 1.48. So for each increase in VR, so if you went from a VR from 1 to 6, your odds of mortality increased. And the mortality outcome here was 60-day mortality. So the outcome here was 60-day mortality. So in the San Francisco General cohort, which was an observational cohort, VR was an independent predictor of mortality, and it remained so after we also adjusted for the Apache 2 score. In the FACT trial, the findings were very similar. The VR remained independently associated with increased risk of mortality after adjusting for a number of respiratory variables, including PF ratio and PEEP, driving pressure and oxygenation index, and also after adjusting for Apache 2 scores. You may see that the odds ratio is slightly lower in this population because there was a significant baseline mortality difference. In the San Francisco General, mortality was approaching 40%, whereas in the FACT trial, the overall mortality was, I think, about 27%. So we then tried to devise a simple way to stratify these ARDS patients into groups which we can study and see whether or not we can use it for prognostic enrichment. We used a very straightforward cutoff. So we used patients with VR of greater than 2 as a high VR group and VR of less than 2 as a low VR group. And using this, we found that both in the primary data set, which was the San Francisco General data set, and in FACT trial, there was VR was significantly associated with with a decreased probability of continued mechanical ventilation. So the low VR group is represented by the green lines, and the high VR group is represented by the red lines. So what this says is that if you have impaired ventilation or problems with CO2 clearance, you're more likely to be ventilated for a longer period of time. And then next, looking at mortality as an outcome, and I showed you before when we used those randomized controlled trial cohorts, this is for the San Francisco General cohort. And unfortunately, it's not, this isn't clear enough to be able to decipher it. But essentially what this chart shows, on the x-axis, we've plotted the PF ratio, and on the y-axis, we've plotted ventilatory ratio. The first thing to note is that the correlation between PF ratio and ventilatory ratio is quite poor. Specifically, in your mind's eye, if you draw a line at a PF ratio of 100, and to the left of that line, you can see in severe ARDS, there is very little correlation between VR and PF ratio. Moreover, the mortality rate in the high VR group was 51% compared to the low VR group, which was 34%. And this was statistically significant. So to summarize, VR correlates with physiological dead space now across 2 ARDS cohorts. I haven't shown in this paper that was published recently, we interrogated another multi-center cohort which showed the same findings in about 150 patients. VR is an independent predictor of outcome in ARDS, and VR is a useful variable for prognostic enrichment in ARDS patients. Of course, the caveat here is that these are all secondary retrospective analyses, and we need to confirm these findings in prospective studies. Okay, so next I'm going to show you predictive/prognostic enrichment using some of the studies that I've been doing recently, and I've been engaging most of my time doing. So we've talked about the biological heterogeneity in ARDS. We have used a technique called latent class analysis in randomized controlled trials. And again, important to appreciate the caveat that all the studies that I'm about to show you are secondary analyses. Latent class analysis is a form of mixture modeling. It's a form of unsupervised clustering. And the idea is that in a heterogeneous population, demarcated here in the graph by the bold lines or the continuous line, there are some hidden subgroups or unmeasurable or unobserved classes that exist. And the idea here is that we input a certain amount of data, be it clinical and biological, which is what we do, into data, and it seeks to find some of these subgroups. We have now used latent class analysis in 5 trials. The ARMA, which I've already presented, which is low tidal volume versus high tidal volume. Alveoli, which was high PEEP versus low PEEP. FACT, which was the fluid, liberal versus conservative fluid therapy. HARP2, which was a UK and Ireland randomized controlled trial that looked at the efficacy of simvastatin versus placebo. And SAILS, which looked at the efficacy of rosuvastatin versus placebo. And across all 5 of these trials, we have consistently identified 2 phenotypes in ARDS. Phenotype 1 is represented here by the blue line. It's called the hypoinflammatory phenotype. And phenotype 2 is the hyperinflammatory phenotype. The x-axis, what you see are the variables that we use to input into the model. These are just the continuous variables. And this is a combination of demographic data, clinical data, physiological data, and plasma protein biomarker data. And this is all data at baseline. On the y-axis is the average of the standardized values for each of these continuous variables that you see. So at either end of this, so at this end and at this end, you see variables that separate the 2 classes the most. These 2 classes, it's important to appreciate, are heterogeneous to each other, so they're very different from each other, but homogeneous within. So there's a lot of similarities within these phenotypes, between the patients classified in this phenotype. The hyperinflammatory phenotype is associated with exaggerated inflammation. And it was associated with higher levels of plasma IL-8, IL-6, soluble TNFR1, PI1, and higher levels of creatinine and bilirubin. It is also important to appreciate that the use of vasopressor use in this cohort was also higher. Conversely, the hyperinflammatory group was also associated with lower bicarbonate, lower protein C, lower systolic blood pressure, and lower platelets. Almost consistently across all 5 cohorts, approximately 30% of these patients had hyperinflammatory characteristics and were assigned to the hyperinflammatory phenotype. So here's the prognostic enrichment part of this. Again, as you can see, in the red is the hyperinflammatory phenotype, so these are the patients that are more inflamed, and in the green is the hyperinflammatory phenotype. And consistently, across all 5 cohorts, you can again see that there was mortality was significantly higher in the hyperinflammatory group compared to the hyperinflammatory group. More interestingly, perhaps, we also noticed a heterogeneous treatment effect, or a differential treatment response in 2 of these trials. First to PEEP in the alveoli trial, and to fluid management in the FACT trial, i.e., within the subphenotypes, the response to this randomized intervention was different in the two phenotypes. Most recently, we used randomized controlled trial in the HARP2 study. I will remind you, this is a UK and Ireland trial that tested the efficacy of simvastatin versus placebo. In the original trial, both in this and in the others, there was no difference between the treatment and control arm in the original trials. In HARP2, there was no significant difference in outcome between mortality in placebo versus simvastatin. However, when we looked in the hyperinflammatory group, there was no survival benefit confirmed with simvastatin therapy. In the hyperinflammatory group, we observed a significant survival benefit associated with simvastatin compared to placebo. And again, I emphasize that these effects were not observed in the original trial, and also when we stratified the original trial by measure of disease severity, so in the case of ARDS, it's a PF ratio, or if we use the Apache 2 score, this effect was not observed. So this suggests that the severity that we are extracting, the information on severity that we're extracting using our phenotyping and latent class analysis, cannot be extracted from clinical variables alone. So there are some issues with these latent class models. They're incredibly complex. We use somewhere between 30 and 40 predictor variables in these models, and essentially that renders them unusable in the clinical setting. So the idea is to try and identify these phenotypes at the bedside. Also, these are logistic regression-based models, so we wanted to find a novel method of identifying some important variables to build small, simple, parsimonious models that could potentially be used at the bedside. And we've successfully done this. We've identified models which use 2 to 4 variables, which are logistic regression-based models, and these show reasonably high accuracy in identifying phenotypes in these populations that we have previously studied. There are, of course, some limitations to the work that are presented, both in terms of phenotyping and in the previous work. It must be appreciated that these are all secondary analyses, and whilst we have met the criteria that gives credibility to such analyses, we must have some healthy skepticism when interpreting this data. The generalizability of these phenotypes is also at the moment questionable. We have limited our studies to randomized controlled trial populations, and as you remember I'd shown before, that mortality in these are very selected populations, and mortality is quite low in these populations. And also, the phenotypes that we have identified are data specific. They're very specific to the data that goes into the model. And it's difficult to know whether in a broader setting, whether these phenotypes are applicable, but we think that they might be, but it needs to be tested. And also, whilst we have said that these patients have hyperinflammatory characteristics, the relationship is purely associative. There is no causal pathways that we have identified, and in order to do that, we need to engage with different research platforms. And also, one of the things that's holding back using this in clinical trials at the moment is that there is no effective and rapid point-of-care testing that will enable us to quantify these biomarkers. Particularly what we use in these models is IL-8 and protein C. So to summarize the findings of ARDS phenotypes and endotypes are increasingly being identified in critical care syndromes. They offer a route to prognostic and, in some cases, predictive enrichment. Currently, they're all limited to secondary analysis, and rapid identification of phenotypes is essential for successful translation. So, to conclude, heterogeneity is a key factor in multiple failed clinical trials in ARDS. We have limited high-quality data that can guide our management of patients in ARDS. Physiological and radiological tools could be used for prognostic enrichment, and I apologize. I thought I'd be rushed for time, so I've taken out some other work our lab's doing to try and refine the radiological interpretation of ARDS, something called the RAL score, if you have time to look it up, or we can talk about it later, which has been published by Lorraine Ware's group, which seems to be very promising in trying to prognostically enrich patients with ARDS. And biological tools seem to show promise in trying to predictively enrich these patients in ARDS. And these strategies in the future may pave a pathway to try and conduct clinical trials in ARDS that may be positive. I've got to acknowledge some people who have helped me along this, particularly Carolyn Calfee, who's my mentor at UCSF, and Kevin DeLuca, who's a professor of statistics, who I work very closely with. And of course, all these studies it's through the efforts of multiple people, and I want to thank all of them and co-authors of all the studies that data I've shown you. So, I'm happy to take any questions.
Questions from the audience?
Yeah, thank you. That was a great talk. I just had a question. It was very interesting in terms of trying to subtype people by the biomarkers, and I think I agree with you. That's probably the way to go, and that's probably going to be directing care. When you looked at the hyperinflammatory ARDS versus the hypoinflammatory, was there any difference in the clinical presentation of the hyper versus hypoinflammatory in terms of cause of ARDS or their physiology or anything along those lines?
Yeah, great question. Thank you. So there were some notable differences. Non-pulmonary sepsis was more frequently encountered in the hyperinflammatory group, whereas pneumonia, by and large, constituted the hypoinflammatory group. There were key differences in things, the Apache score, SOFA score, and there was a greater propensity towards organ dysfunction in the hyperinflammatory group. And what's interesting is that the only area where there were no significant differences between the two study groups were things like temperature, and none of the respiratory variables were different between the two subgroups. So things like mechanical ventilation, PEEP, arterial PCO2, oxygenation, they were largely similar between the two groups. The only thing that in a couple of the cohorts that were different was minute ventilation, and in part of my brain, somewhere along the lines, I'm hoping to combine these two projects and see whether ventilatory ratio might be different between two groups. Because in terms of looking at a sort of a biological output for physiological respiratory variables, I think dead space probably offers us a route, albeit a very blunt route.
Maybe I can ask a question.
Sure.
Your slide, you suggested that that subphenotypes would differ in their response to PEEP and fluid management.
Yeah.
But you were coy, you didn't tell us which direction it went. So which direction did those two interventions go?
So I was coy not because I didn't want to disclose it. It's all out and published. It's because they went in different directions for the two studies, and it becomes incredibly complex to present that idea. So basically, it favored higher PEEP favored the hyperinflammatory group, and it was the opposite. So conservative fluid favored the hyperinflammatory group. So it's opposite, and it becomes very complex in numbers. So I didn't want to.
That's not so complex, and I'm wondering, should we look at our patients? I know we're not measuring IL-8 or protein C routinely, but bicarb, whether we're using vasopressors, creatinine, and bilirubin, we would have those measured in everyone. And should we look at those now, try to classify folks as hyper or hypoinflammatory, and maybe be a bit more generous in our use of peat in the hyperinflammatory folks, and maybe not dry them out as much?
So that's an excellent question. The very quick answer to that is no. I don't think it's ready for prime time. But to build on that question, I think there are two things to answer here. Number one, that we looked at a clinical classifier model using standard logistic regression, which was published in Katie Famous's paper, which was in the Blue Journal in 2017. But that didn't perform very well. However, I'm also presenting tomorrow at 11:30?
11:30 at the HLI. It's more of a research-based thing, but anyone is certainly welcome to attend that.
So if you want to know more, I have actually developed a clinical classifier model using machine learning. It's a thing called gradient boosting machines, which are incredibly promising. And we think there might be a route to use auxiliary variables that aren't biomarker-based to be able to identify these phenotypes, which could be clinically applicable. However, sort of I'm naturally quite conservative with these things, and I think they need prospective evaluation. But we certainly have promising methods to be able to identify these in real time, and on the proviso that it bears up to the scrutiny of a randomized controlled trials, it could potentially impact clinical practice.
Aaron?
Thanks for the thought. I'm fascinated by the hypo and the hyper states. HLH secondary HLH is probably a very prominent inflammatory state, and patients, I'm not sure if patients with HLH have ARDS or even with other patients. Do you have any experience with the treatment of ARDS if they have it in that particular group that would have high inflammatory response?
So the last part of the question is, have I got any experience with
Patients that have HLH who are in the ICU setting?
Yeah.
They have ARDS. Does their therapy differ in their survival?
Yeah, so the question is, HLH is associated with a hyperinflammatory state. Is ARDS more frequently encountered in these patients, and do I have any experience with it? Unfortunately, the answer to that is no. I don't know whether HLH is associated with the increased incidence of ARDS. But what I do know is that we probably don't tailor our therapies to these patients specifically to counter that. It does bring into mind an interesting question as to whether, if we are to operationalize this, what is the best anti-inflammatory drug to test in these populations? Certainly simvastatin is probably not it, although that's a low-hanging fruit because we already have some evidence for it and there is an infrastructure set up to conduct that trial. I mean, I hate to say it, but do we then start engaging about steroids? Although, again, the interaction of steroids is not so straightforward. There's a recent paper that's come out by Anthony Gordon and his group from the UK, which looked at a sort of a similar. They've described in sepsis two groups, which is an immunosuppressed group and a normal group. And what they found that if you give the normal group steroids, it kind of drives them into being immunosuppressed and they have worse outcomes. So the only people who did worse with steroids were people. It's essentially what I'm saying is that these things are very data-driven, and the biological systems that we study are incredibly complex. And one of the reasons why I'm sort of saying that we should be cautious is that we're studying very complex biological systems, and it's not as simple as just plugging and playing. And I can give you other examples, perhaps later, of routes of prognostic enrichment using biomarkers where we thought one thing would happen and completely the opposite thing would happen. So I think caution is the way forward.
John?
Pratik, I really enjoyed that, for sure.
Have I cured ARDS, as I promised earlier?
We will be out of business, man. We don't want to do that. Let's looking at your whichever of the two, the VR, the ratio, or your biomarker based, and thinking about, I don't know if you have a sense, let's say for the biomarker, the hypo versus hyper, do you have a sense going through the charts and stuff? Part A of the question is what the two sets are dying of. In other words, are the hyper dying of multi-organ failure and withdrawal of care, and the hypo dying of more pulmonary death? And I guess just like part B is, might it make sense counterintuitively to focus on the hypoinflammatory or less multi-organ failure group for your sort of ARDS, like lung-focused treatments? Just a thought as I'm watching those slides.
That's a really great question and a really difficult question, so thank you. I'm going to approach this in two parts. The first part is that we are going to pretend that this is a conversation between you and me and nobody else can hear it, and we'll keep it to that. But, you know, what is the hyperinflammatory group interests me more because at the back of my brain, I have an understanding of what Ashbauer and colleagues and subsequently described as ARDS, which is this acute inflammatory process, and what the basic scientists study as hyperinflammatory when they have their wonderful models. So I just often wonder whether we're just isolating those patients, right? And actually those are the patients that may actually have ARDS, right? Which then makes the hypoinflammatory group incredibly heterogeneous. And that's one of the things that we have noticed in terms of their phenotype, the clinical phenotyping. They're a very heterogeneous population. It's very hard to nail anything specific down. A lot of them have pneumonia, which is interesting. And there are other sort of biological reasons why that might be interesting. And so I think it definitely warrants studying that population separately, and perhaps then we can do some further subgroup analysis in those patients to see whether we identify anything. But taking that conversation beyond that, the question is, does this hyperinflammatory phenotype, is it restricted to purely ARDS, or can we find it in other critical care syndromes? So is it a function of, say, for example, a hyperinflammatory phenotype that you get with multi-organ failure? So can we find it in sepsis or in patients who just come in generically? So say people who, not something like traumatic brain injury, but if they come in with critical illness that leads to multi-organ failure, can we identify that? And I think that's one of the steps we're working towards to see whether this is something that works beyond just ARDS. And part of the motivation for that has arisen from the SAILS trial, which I don't know if you remember, tested rosuvastatin versus placebo. That was specifically in a sepsis-associated or infection-associated ARDS population. And the findings were so robust compared to all comers in ARDS that we wonder whether we can transport this to sepsis too.
Good. Well, I'd like to thank Dr. Sinha again for an outstanding presentation. I'm absolutely fascinated. We'll pursue it more.
Thank you. You thought that was okay?
Yeah. Lots of good clinical stuff, which but obviously you proved a lot of interest.
Yeah. No, it's interesting work. You know, it's it's very promising. Hi.
I was curious as to whether you studied the ventilatory ratio of your composition, or did you have a chance to go from a supine prone and then look at the ventilatory ratio?
Yeah.
What happens physiologically?
Great question. I've done it in 5 patients. Yeah.
What do you see?
And the patients 3 of the patients, the VR went down, and they all survived. But it's anecdotal evidence in 5 patients, so I don't want to get too excited. But we're planning to see whether we can use it as a marker to see responders versus non-responders.
And then I guess the next thought process to that would be, should you just, within the first 4 hours, measure the VR and then immediately tell the patients and not really wait for further physiological deterioration?
Yeah, I think, again, our patients are so complex that I think